as you all know, this in our 7 to 8 a.m. Echo sessions are 8 topics that rotate. So this is the 7th of 8, diversion of buprenorphine. We typically update these periodically. I updated this a couple of months ago, and I actually looked recently, and I haven't seen any new research since about 3 months ago related to diversion, but there will probably be another group here coming up. So these are our global learning objectives that all of the AM sessions are meant to fall under. Kind of what we're going to look at today and specific to this session is sort of look at the prevalence of diversion in MAT, including in Ohio. And I tend to use the osamagram data for that. Understand some of the risks associated with diversion, and then appreciate some strategies to reduce the risk of diversion. So this is kind of, if you think about, or when I look over the research related to diversion, this is sort of the theme that will come out, is that basically, and we can think about this however we want to, right? But the belief is that it's the policies that restrict access to buprenorphine that are really sort of what create a situation where there is diversion. So the rationale being, if we made it easier for people to access buprenorphine, then there would be less of a street market for buprenorphine. And there's also the belief that the literature suggests is that really we should be more focused on increasing availability of buprenorphine for a lot of reasons, not just to reduce diversion, but to reduce overdose risks as well. But there's other arguments, and these are really just sort of what the scholarly literature suggests. This is still the same. This is a 2014 article, but there is still not really evidence to suggest the best ways to reduce diversion, especially when it comes to buprenorphine. So it's still a little bit of the Wild West in terms of trying to figure that out. So here's some definitions that are kind of important, and the literature oftentimes conflates these terms, which makes it kind of hard to understand sometimes what they're really focusing on. They'll think about them as the same, although they're actually different. So misuse is when the person is using their own prescription of buprenorphine in this case, but they're using in a way that wasn't intended. So one of the more common ways is that, I know it doesn't make sense from a pharmacological perspective that people would be injecting buprenorphine naloxone. However, if you look at samples of patients after patients after patients after patients, there tends to be about 16–20% of a group of people are still injecting at least sometimes their buprenorphine naloxone medications. So that would be an example of misuse, or any intranasal use, or taking more than was prescribed. That's different than diversion, which is a different person accessing that medication. And that can be either voluntary or involuntary. So a person's medications who get stolen, that would still be considered diversion. Though clearly, if they could supply a police report that, and it was a one-time thing, that might affect the way in which you think about that diversion incident. So what is the prevalence of diversion? I like to start with this slide because I think in the United States, we divert medications a lot, and therefore patients may not really understand sometimes the significance of diverting their buprenorphine medication. There's a number of these studies where they will sample a cross-section of the United States and kind of wonder about diversion issues across households. And typically in this study, they estimate that about 17 million people use stimulants, benzodiazepines, or opioid analgesics that were not prescribed to them. And then when you get at things like allergy medications, pain relievers, antibiotics, you're looking at about 20-some-odd% of people report sharing. And I always joke that whenever I go down south to see my parents, if they hear me with a cough, they're wanting to give me some kind of medication they have in the counter. So people just sometimes don't think about the significance of diverting medication, because we do it with a lot of medications. So what about MAT specifically? This was a 2013 study, and they found that about 18% of people who were engaged in methadone or buprenorphine treatment sold, gave away, or shared their prescriptions And you can see that number is kind of consistent. It seems that across studies, it's about, 15, 20%, somewhere in there, of folks who at one point in time diverted their medications. Studies find that all three sublingual formulations are abused or diverted, though the sublingual film are less likely to be abused or diverted than either tablet formulation. And that's pretty consistent too, as the film essentially seems to earn you a little bit less on the street too. So it's a little bit less, and that's including in Ohio. So a little bit less attractive to divert, though it would still be diverted. So what about in Ohio? This is the most recent Ohio Substance Abuse Monitoring Network drug trend report that I could find, June 28th to January 2019, that covered that period of time. If y'all are not familiar with it, it's really interesting. And the research design is really interesting. Essentially, they sample law enforcement, they sample first responders in terms of like EMT workers, they sample criminal justice folks, and they sample people who are using drugs on the street or in treatment, as well as counselors, psychiatrists, psychologists, physicians, basically anybody who kind of has a hand in the recovery or the drug use world. And they kind of wonder what's happening in Ohio. So Suboxone, they report as being highly available for illicit use throughout Ohio. Though they found in that period, it was Toledo last time, and now they're finding more increases in Cleveland, Akron, Canton, and Athens. So those areas, they're reporting even increased spikes, but basically people are finding street buprenorphine pretty much consistently across Ohio. When they ask people why is there all this diverted Suboxone on the street, patients or people will typically say it has to do with clinics where there's little patient oversight. So, basically it's just medication and no treatment. And then always, of course, the dreaded dark web where people are getting these medications. Suboxone is a form of currency, so people will use their Suboxone to buy heroin or to buy cocaine or to buy methamphetamine. And the sort of slang is octagons, rounds, subs. And then, so why, they ask, so why are people using diverted medication, Suboxone? And they'll say that they're doing it to avoid withdrawal. I didn't put in here also, they'll have these, you'll see these periods of time where there's a certain, they'll call it a bad batch. They'll go through a region and a number of people die. And that's another time where there's at least reported, I don't think there's research or quantitative research to back it up, but people will report that they're more likely to divert their medication to their friends so that they can avoid an overdose. And also people will be trying to get Suboxone during that period of time to avoid an overdose. So there's kind of at least a qualitative correlation there. So the film strips of Suboxone will get you anywhere from $10 to $30. And then the 8 milligram tablets of buprenorphine naloxone will get you $20 or $25. So that kind of, again, goes to that point of, in general, a person could earn more money from selling their diverted tablet than film strips in general. And then they also found that people who are using diverted Suboxone on the street, that 70–90% were using it orally. And then again, you got this group that's intravenous, 10 to 30%. So this was a kind of interesting study in 2019. They sampled a number of administrators at the Ohio Alcohol and Drug Mental Health Services Administration, and they sampled them in 2015. So there's a little delay there, but they wondered, why is it that it's so hard to have access to buprenorphine across Ohio? And basically, one of the biggest themes that came up in these surveys or these interviews were that the public, and in particular law enforcement, was having issues with finding diverted buprenorphine being sold on the street. And that created this kind of stigma against the treatment in general. And definitely here in the county where Neomed is located, that's a big issue, where Child Protective Services here, as well as law enforcement, really have significant negative attitudes towards Suboxone treatment, and they'll argue it's because of diverted medications. And then that affects what we talked about on the morning here, where patients then who are involved in Child Protective Services or involved in criminal justice are being mandated to get off of their medications. And a lot of it has to do with this kind of stigma that stems from finding diverted medications for whatever that's worth. So there's a 2017 study where they asked people who are engaged in Suboxone treatment, what was their rationale? Like, why did you divert? So 22% of the sample said it was okay to share Suboxone with a dope sick friend. 38% believed it was okay to do that, or they did it when they were doing it just to save lives. And again, that's kind of that issue when there's a bad batch in the community or some concern for your friend that they may overdose. About 52% of the sample said it was never okay to divert or share. So again, you got about 48% that did believe it was okay at certain points. So of that group, that 48%, that 107 patients who did divert, 59% they did it to help a friend. 57% said they needed that. They did it to get money. 27% said they didn't need the whole dose. And 59% didn't want the whole dose / wanted to get high. So you kind of think about that like your Suboxone vacation or whatever. And I think these are things that then the research would suggest you may want to ask about these issues with your patient. So wondering about their financial situation and wonder whether or not that makes it more likely that they would want to divert their medication. Obviously making sure that people have a sufficient dose, but not too significant of a dose. And then, so consequences. So obviously diversion can lead to harmful medical consequences, including fatal overdose, because people who are receiving diverted medication are not under the care of a medical professional. It can lead to harmful social consequences. So clearly it's illegal, right? So people can really impact their recovery by catching some kind of criminal justice case. That it could be a rationale for people to lose custody of their children. So have child welfare involvement. So there's, things that are not recovery congruent that can happen when people are diverting their medication. And clearly, people can lose their access to buprenorphine. And one thing I would say there is that and I kind of wonder what y'all's thoughts are about this, but again, if you look at all these studies on diversion, kind of what the theme is that if a person diverts infrequently and then is open and honest with you about it and is willing to do something to make that less likely, authors would argue that's somebody to keep in treatment. All things being equal, honesty about it, infrequent, and agreeing to a plan to make it less likely, versus a person who is dishonest about it or is frequently diverting their medications. That would be a person that would be much more likely to be discharged from treatment. So that's kind of the line they look at. So essentially buprenorphine does seem to have a safety, a higher safety profile than does methadone, and lower, which is always surprising to me, the lower rates of drug diversion, because there's so much oversight with methadone, but nonetheless, that's what this study suggested. And then 50% of buprenorphine-related emergency department visits were for non-medical use of the drug. So basically, someone who got it from a diverted source, or where it was diverted. And 9.5% of hospitalizations for drug ingestion by children less than 6 years, and lower rate for film than tablets. So obviously, and I know that this, that part of your treatment contract, you really want to be sure that that the person has a plan to keep it away from children, right? And even if they don't have children, there may be children that are in their home for whatever reason. So this is a 2018 study. They sampled a cross-section of buprenorphine prescribers, so PAs, NPs, MDs, DOs, about 1,100 across the states. They're just kind of wondering about attitudes towards diversion. So 79% of this sample assessed via urine drug screen for presence of bup. They didn't talk about bup metabolites, which was interesting, but so I'm not sure if they were doing that or not. 35% saw patients 2 times a month during the first 60 days. 26% saw patients 1 time a week during the first 60 days. So, pretty frequent visits and oversight. 66% initiated medication counts. And of this sample continued, so 50% had a strong agreement, so it's like a Likert scale, strong agreement with terminating patients who were diverting. About 30% were in agreement, so a little less strong with terminating patients who were diverting. 49% reported that diversion was a moderate community problem, a moderately significant community problem. 24% roughly said it was a significant problem, so higher, and about 12% reported as an extremely significant problem. So then they kind of looked at, did there seem to be an association between the provider's belief about whether or not it's a community problem and then their willingness to terminate patients. So basically, if I think it's a big problem in my community, am I more willing to then terminate my patient who I suspect of diversion? And they did find a significant relationship there, that the more the provider thought it was a community problem, the more likely they were to terminate patients for diversion, which is sort of interesting, and about what sort of that means. And they also found that psychiatrists and addiction specialists were less willing to terminate treatment compared to non-addiction and non-psychiatry prescribers, which is also interesting. Like, why are they less willing? And we can all speculate or wonder about that. So what can you do? A lot of the early research and practices in this space were really borrowed from methadone maintenance treatment. So some things in terms of, and this is sort of like, these would be criteria to allow your methadone patient to have more take-homes, because essentially you would believe that it would be less likely to be diverted. So no recent drugs of abuse, including alcohol, coming to the clinic regularly, no serious behavioral problems at the clinic, no known recent illegal activity, stable home and social relationships, the longer period of time that they were in comprehensive treatment, assurance that take-home medications can be safely stored. And then there's always this balance, does that rehab benefit outweigh the risk of diversion? So as example, okay, I've got a patient who seems to be doing well in their job. If they have to come here frequently, they may lose their job. Does it make more sense to make them come and they'll lose their job, or does it make more sense to give them a little bit longer rope and allow them to keep their job? These are decisions you all make all the time. But it's more specific to OBOT settings, what can you do? So obviously the urine test for the bup and bup metabolites and other drugs of abuse, initiating the pill counts and medication log, sometimes doing unannounced random targeted urine test and pill count, and clearly you'd want to have that in your treatment agreement so the person would know that that's a expectation if they're going to work with you, that could happen. Doing observed ingestion, so as frequently as 3 times a week, and at least, again, there's not research to really back this up, but the literature would suggest that 3 times a week gives you a pretty good level of oversight. And that if you can do that, if you're concerned about somebody, that may be adequate. A limited medication supply, so as a week of medication or as little as 3 days. Obviously, you're looking at your Ohio Automated Prescription Reporting System. One thing I'd say about observed ingestion too, and it kind of goes to Chris's presentation last week at 7, if you happen to be blessed with having a patient whose family is positive and supportive, supports their family member in buprenorphine treatment, they could be someone who could do observed ingestion. And I think somebody on here was talking a couple of weeks ago about even using some video conferencing technology to observe patients taking their medication. I think, and Dr. Dugan can say this too, I think that pharmacists may be able to do that too, but she can correct me if I'm wrong. Obviously, you could also be looking at your buprenorphine extended release injections or buprenorphine implant. I know there's a number of people here who have patients who are using those medications because of diversion concerns. I think it'd be interesting for us to hear from you all kind of what those conversations were like with your patients and how you all made that decision that that was going to be what they were going to do. And how did you kind of get their buy-in to that? So what else can you do? Discuss diversion and misuse regularly. So that would be part of your assessment, is wondering, even early on, what are reasons why you would divert? What would be the consequences of diverting? Having conversations with patients about that. I know from doing this about 20 years or so, holidays can be a time when people divert because they're trying to get some extra cash to get children presents and things like that. Uh, all kinds of reasons why. So it can be just kind of helpful to know what are people's triggers for diverting and what are ways they could avoid that. Um, Obviously, regular review and monitoring of the dose adequacy and the treatment response, so that people aren't taking home more medications that they need. And you can use your CALS assessment and things like that to try and determine whether or not the person seems to be sufficiently medicated. And this gets more at misuse, but looking at any non-healing, fresh track marks or intranasal irritation. And then what else can you do? So contingency management, that's been a tried and true method in medication-assisted treatment, where basically you reward people for healthy recovery-oriented behaviors. So if they find it valuable to come to the office less, then they will take steps to earn that, and they can have more medications and less frequent visits. That can be really rewarding to people. Treatment agreements with the 24-hour notice of monitoring. As much as you can, collaborating with treatment partners, that can be pharmacists, counselors, non-using family members. Access to full psychosocial support. So maybe thinking about person where their diversion risk for intensive outpatient programs, where maybe they can do observed dosing there. Consider patients' rationale for diversion before intervention. And I would say their honesty too. So again, you all would decide this, but if it's a infrequent behavior and they're honest about it, and it's they have a rationale and they describe it for you, and there's something you can work with, maybe that's somebody that you keep working with. If it's somebody who seems to be dishonest or is doing it frequently, and it seems to be more of a side business than actually a recovery process, then that would be someone you'd probably treat differently. And that's it. So be open to any